Right, hi. Glucose. We've got just a bit of a standardization here. So this is the name of the presentation, and then we have some subset things. That brain's about to jump, sorry. So we have differential, history taking, examination, investigations, and management. So whichever are lit up what we're covering. So this slide will cover differentials, history, and the examination. So history and exam is quite straightforward for glucose levels because basically it's going off blood glucose and the consequences. So up or down, and down, just remember that 4 is the floor, so 4 millimoles is the limit. Anything below that is classed as hypoglycemia, and then we'll do the hyperglycemias later. So for raised glucose, these are the key things you need to know. So the first of all, diabetes. Okay, patient with diabetes is going to be hyperglycemic based on whether it's type 1 or type 2 for different reasons. Okay? Stress hypoglycemia is a big cause. So any sort of infection or acute illness, pregnancy causes, sorry, that should be hyperglycemia, causes hyperglycemia, okay? And that's because cortisol being released by the sympathetic overdrive is powerfully gluconeogenic. So cortisol acts on the liver predominantly because that does 90% of all gluconeogenesis and glycogenolysis, and it forms new glucose or breaks down the glycogen stores to make glucose. You also have iatrogenic causes of hyperglycemia. So that would be things like thiazides, beta blockers, and then classically, those are like the key ones, but stuff also like antidepressants cause it as well. But those are the key ones to note. What else is key? Glucocorticosteroids. So if you give a patient, if patient's Cushingoid, or you give them oral steroids, then yeah. So down, the most common cause is insulin. Okay, so insulin, such as the drug given insulin or insulinomas, so tumors that secrete insulin, or certain kinds of lymphomas will cause antibodies to be raised to the insulin receptor. So it's like having too much insulin. Okay, so a retroperitoneal tumor commonly would be caused by things like an insulinoma, and if you have a retroperitoneal tumor that is an insulinoma, so massive growth in the pancreas, loads of insulin is being produced, it's going to cause loads of glucose uptake because of the insulin-dependent GLUT receptors, GLUT4. So they all flood into the cells, and then we don't have enough insulin, so we don't have enough glucose floating about, so we're hypoglycemic. And the liver as well, because the liver is going to be involved in producing and breaking down things and making sure that glucose can be brought out so insulin can do something. So any defects or cirrhosis, and that includes drugs, so any hepatotoxic agents will cause that issue as well. And because we have all the endocrine cascade, if we have a loss of a loss of glucocorticosteroids, that should say. So any sort of steroid loss, pituitary or hypothalamic issues. Okay? So the patient who's hyperglycemic, their presentation is usually polyuria, dyspnea, fatigue, weight loss, hyperventilation if it's type 1. If it's type 2, it's usually indolent, so there's no symptoms. They might have a bit of weight gain. Okay, that can progress to recurrent infections and things like that, but this is your classic type 1. Okay, and then hypoglycemia, there's sort of like a compensatory effort briefly. So sympathetic overdrive causes sweating and palpitations, but because you don't have enough glucose, that cannot persist for long. So the sympathetics, they just don't have glucose to power the metabolic rate, so they become weak, they start tremoring, that's also a bit of sympathetic as well, and before you know it, the dysregulation of metabolic rate causes seizures and altered level of consciousness, and then ultimately the hypoglycemic can progress to a coma. So, insulin secretion. So this is just to remind you that GLUT2 of the beta cell of the islets of Langerhans in the pancreas, the endocrine pancreas, loads of glucose. Glucose comes in, it's metabolized to ATP, and then you have these potassium channels which are sensitive to ATP. So ATP binds them, closes them, so potassium cannot leave the cell. You can't have potassium efflux, which means the cells have a propensity to depolarize as opposed to repolarize, And you have voltage-gated calcium channels, so depolarization occurs, that turns on the voltage-gated calcium channels, calcium comes in, and calcium is a cofactor that causes exocytosis. You see that at the synaptic bulb. So calcium comes in, these vesicles are full of insulin, this calcium influx causes the vesicles to fuse, and insulin is released. So that's how raised glucose causes the release of insulin at the beta cells. And then a quick nod to the GLUT receptors. So GLUT1, GLUT2, GLUT3, GLUT4 and GLUT5. So GLUT1, insulin is not required and it's seen in red blood cells and the blood-brain barrier. GLUT2 has low affinity to glucose, so we need loads of glucose to activate it. And that's the liver and the pancreas sensors. In particular, that's GLUT2, right? GLUT3 is the brain and the baby, so the placenta. And this has low Km, which means it has a high affinity. So there's an inverse relationship between Km and affinity. So ignore Km and just focus on affinity. So there's a high affinity in the brain and in the baby because the brain cannot store glucose, so it has to suck it all up. The placenta growing, so it has to suck it all up. That's GLUT3. GLUT4 is the insulin-dependent one, which is often a question because it's the key insulin-dependent one, right? So peripheral action of insulin binds to it, activates GLUT4, and then the muscles and adipocytes can take in the glucose for the metabolic functioning or for storage, right? And then GLUT5 is the enterocyte. So this is how dietary glucose enters. So metformin is first line for type 2 diabetes. It turns off gluconeogenesis and glycogenolysis in the liver, but it also downregulates GLUT5 receptors, so you can't uptake the sugar from your diet, basically. And then just a quick bit of a biochem here. I'll outline the anatomy of the insulin receptor. So it's a tyrosine kinase linked receptor. Basically what you need to know is GLUT4 is linked to insulin. Okay, so insulin binds, activates GLUT4, and that causes utilization of glucose brought into the cell. So these are the thresholds in your investigations when you do a BM, fasting and post-meal. Okay, so the normal patient in a fasting state, so they haven't eaten for a while, their glucose should be less than 6. If they have impaired glucose tolerance, it will be 6 to 7, and anything above 7 is the diabetic threshold. Okay, for post-meal patients, you've just had breakfast, or you've just had, I don't know, a chocolate bar or whatever, less than 7.8 is normal. So you can see how this can quickly become confusing, because if the patient hasn't eaten for a while, greater than 7 is diabetic, but less than 7.8 is normal. So caloric restriction to test this is difficult, because if the patient cheats and eats a bagel beforehand, they're either diabetic or they're normal, and they've lied to you. So that's difficult. Impaired glucose tolerance is 7.8 to 11 and 11 plus. So really it's just numbers to remember. And if you just remember that you have one solid number, less than this, greater than that for normal and diabetic, and then the impaired glucose tolerance, there's 2 numbers in the middle because it's the second one. That's how I remember it. If it helps you, it helps you. So quick nod down here, A1C that you can also use. This is the other way you can use it. So you can do a fasting blood glucose, a post-meal blood glucose, or an A1C, which calculates your blood glucose concentration over several weeks. So it's a marker of a more longer thing, so it's probably a little bit better, some would say. You want it to be 48 millimole. Oh gosh, I do apologise. So you want it to be 48 millimoles per mole. That is the hyperglycemic threshold, which is greater than 6.5%. So according to the American Diabetic Association, that's your marker. 48, boom, is the diabetes level. Okay, so these are just 6, 7, 8 numbers to learn, basically. And those are your classic investigations. There are a few more that we'll go into. Whoops, that came out badly. So bedside, bloods, imaging, and special. So bedside, obviously, you can do a BM. Bloods, you need a full blood count, LFTs and UNEs. LFTs, because as we said, any liver issues can cause hypoglycemia. UNEs, because you need to check renal function, because diabetes uncontrolled is nephrotoxic. You'll have diabetic nephropathy. You could also throw in an ophthalmoscopy for bedside if you're so interested. Toxin screen, yeah, because stress hyperglycemia, so infections cause it. And then insulin, so you're going to check insulin levels, of course you are. And then C-peptide. So C-peptide is produced in the blood when the liver kicks out C-peptide. So your liver cleaves down insulin, it breaks it down, and releases C-peptide. So if you have insulin from an internal source, then you will have constant C-peptide levels. So the type 2 diabetic, are they making insulin or are they not making insulin? Well, usually they are making insulin. They've got high insulin levels, but they have resistance to it. So you can use C-peptide to do that. In type 1, autoimmune reaction has destroyed your beta cells, so because of that, they can't make insulin, so you don't have C-peptide. So C-peptide is absent in type 1 and is raised in type 2. So that's how you can use C-peptide to differentiate the two if you need to. You can do a CT-MR for insulinomas or retroperitoneal tumours. That's RP tumours, retroperitoneal tumours. You can also test the pituitary gland to see if glucocorticosteroids are being released, because, as we said, glucocorticosteroids causes gluconeogenesis. So if there's an adenoma that's causing too much ACTH to be released, which causes an upregulation of the release of cortisol from the adrenal glands. If there's too much of that being produced, then they will be hyperglycemic, and if there's a deficiency, they will be hypoglycemic. So you can test the pituitary. You can also test general cortisol levels. You can do an oral glucose tolerance test, and you can repeat the other tests as well. And then don't forget A1C. So you don't just need to check blood glucose levels, you can do an A1C as well. In terms of management, you've got the non-medical stuff, which is straightforward. So education, diet, lifestyle, stop smoking. You need to be aware of infections. You need to get frequent eye checks, probably kidney checks as well. You need to monitor your blood pressure and be aware that you're at risk of coronavirus. The medical management of type 1 is insulin. You want to keep A1C at less than 7. Now remember that we said that 6.5 is the diabetic threshold, so you want to keep it less than 7. Yeah, so multiple daily injections versus pump are similar for outcomes, so it's up to preferences. So you can have a pump that does it itself, or you can do multiple daily injections yourself. So if you're more afraid of needles, go for the pump, because outcomes are very similar. So there's not one that's significantly better in terms of outcomes over the other, which is handy because you can pick your best choice. The non-medical management of type 2 is pretty similar. They're usually referred to see a dietetic based on CCG funding. The medical management of type 2 is on 3-month cycles. So you start them on a monotherapy of metformin, so all the M's, monotherapy of metformin for 3 months. If the A1C is not coming down below 48, or the 7%, sorry, then they need to go to dual therapy. So it's metformin and any of the others, any of the other classes. Try that for 3 months. If it's not working, then it's a triple therapy. And there's a whole load of different things that can be given. We're not going to go into it because this is supposed to be nice and quick. So, yep. So, 2 quick question stems for us to practice on. So a 25-year-old female presents with rapid shallow breathing, diffuse acute abdominal pain, and altered GCS. So what is the best match differential? Pause the video here. Hopefully I will remember to say pause the video before we go into the answers. So this is a classic DKA, right? The patient has diabetic ketoacidosis. She's young, so it's more likely to be type 1. Rapid shallow breathing is our Kussmaul breathing. So we're trying to breathe off the acidosis with hyperventilation. The diffuse acute abdominal pain. So DKA should always be in your differential for the acute abdomen, looking at the surgical presentation list, and altered GCS. And this is the acidemia, the raised lactate levels, and the decreased glucose utilization using the GLUT3 receptors in the brain, hence altered level of consciousness. So the best match differential is DKA, and what would you expect her BM to be? So you would expect she's having a hypo, so we have switched to ketone fuel because we don't have enough glucose. We don't have enough glucose for various reasons, but the insulin's not working properly. Whatever, it can be a ton of different things. We don't have enough glucose, so we're hypoglycemic. So we expect glucose to be below the floor of 4, right? 1 investigation need to be urgently run on this patient. Pause the video, have a think about it. So it's in the name, diabetic ketoacidosis. So diabetic, you need to check the blood glucose. Keto, you need to check the urine for ketones, ketone bodies, particular beta-hydroxybutyrate, because acetoacetic acid is the one that's more common as a test, but it's less implicated in DKA. So the beta-hydroxybutyric acid, there's 3 ketones, I can't remember the name of the third one, but the beta one is the one that's most implicated. And acidosis, they need an ABG to see if they have metabolic acidosis, basically. Whoops. Yep, so that's the investigations that you need to run urgently on this patient, obviously vitals. What is the immediate management priority in this patient? So pause the video. So the patient needs fluids and electrolyte therapy, and potentially insulin being given as well. You need to check their potassium level. What happens in DK pathophysiologically is that you have a lot of glucose because you're insulin deficient, because you're, let's say, type 1 diabetic, classically in this patient, right? So type 1 diabetic, your beta cells have been destroyed, you don't have enough insulin, and you've missed your insulin injections. So you're having a hypo, okay? So loads of glucose that can't get into cells. It can't be utilized because GLUT4 is insulin dependent and it can't be turned on to draw the insulin in. So loads of glucose, which means you have osmotic diuresis. So the osmotic potential of the blood and the filtrate is raised. So you pee out more. So you will become hypovolemic. You'll also become acidotic because as you switch to ketone bodies, the ketones are acidic when they break down. Okay, so you've got acid and you're hypovolemic. So you're in a hypovolemic shock and you're acidotic. So the immediate management of the patients are to deal with that. So you need fluids because you need to stop the patient being hypovolemic, and the patient needs insulin and potentially some glucose therapy, right? Obviously, because you need to co-administer the glucose and the insulin so that the glucose can be utilized, because the patient is type 1, they can't use the glucose you're giving them because their beta cells have been destroyed, so insulin is not being secreted. So those are the immediate management priorities in this patient. So, 55-year-old male presentation, unremarkable for weight gain in a company health check. So the BM shows a BM of 13 post-lunch. What is the best match differential? Pause the video. So this is indolent type 2. Post-lunch, we said that those parameters are less than 7.8 is normal. 7.8 to 11 is impaired glucose tolerance, and over 11 is diabetic. So the patient is diabetic on BM, because it's post-meal. He's 55, male, he's in the perfect demography for it, and he has no other signs apart from a bit of weight gain. So what are some factors that blunt the accuracy of A1C testing? Pause the video. So the factors that blunt accuracy of A1 testing include anything that will derange blood cells, red blood cells. So polycythemia, pregnancy, haemophilia, and all those different kinds of disorders. Any kind of hematological thing is going to change the ratio of red blood cells, which will change the ratio of glycated hemoglobin, so it can make the number too artificially high or too low. So in those patients with hematological things or who are pregnant, you need to just be aware that A1C might not be the best option for you. On examination, the patient has reduced VAs relative to testing 2 years previously with best corrected vision. Postulate why. Pause the video. So in diabetes, one of the first things to go are your eyes, diabetic retinopathy, and that's because the capillaries that power the retina are the finest capillaries in the body. So you get a lot of microvascular damage in diabetes, and the eyes are more susceptible. So the patient has decreased VAs because of that, but also the raised glucose levels can cloud cataracts as well. So it can cloud the lens, give you opacities. Yeah, and that's a sort of subacute presentation of diabetes. So there's a few reasons why. Given the patient's diagnosis, what is the mechanism of the first-line medical therapy? Pause the video. So the answer to this is metformin is the first-line therapy. Try it for 3 months and then throw in a second line. Try it for 3 months, throw in a third line. As well as all of the non-medical therapies, diet, lifestyle, dietitians, all that shit. Exercise, smoking. So given the patient's diagnosis, the mechanism of metformin is it turns off your GLUT5, so your enterocytes can't absorb glucose, and it turns off gluconeogenesis and glycogenolysis. Those are the big ones. So it causes weight loss, it's used in weight loss, and it also causes a decrease of glucose being present in the blood for those reasons. And that's the video. Thank you.